Thanks very much, Elaine. We'll have time for some questions after, but we're going to speak to Karleen first, and we'll come back to the floor after that. Okay, thank you.
Thank you. Thank you so much for having me here. I'm just so, I'm so pleased to be able to be here and to talk to you. We're not having meetings like this here in Australia. So I feel really privileged to be here and to be having a conversation with you. And I'm hoping that that's what we'll be able to do, either with the questions or afterwards, because I think there are some things to talk about. And I think that's been part of the problem, that people have been saying we don't want you to talk. But we can't find solutions if we don't have a conversation. So what I was going to just talk to you about, and I'm not very funny, I'm afraid, but hopefully I might be a little bit interesting. That might be a good thing. Earlier this year, with 9 colleagues, I published a paper in a journal called Frontiers in Global Women's Health. And it was about the importance of sex language in pregnancy, birth, breastfeeding, and newborn care. And the reason why all of us had written this paper was because we were really concerned about what we were seeing with changes of language around these parts of female reproduction. And we were worried that what we were seeing was actually undermining research, that it was undermining our ability to advocate for good health care for women and for the mother-infant relationship. And also that it was making it more difficult around public health communications. And so that's why we wrote this paper. And if any of you want to get a hold of it, if you haven't seen it, very happy for you to find me on Twitter or anywhere else, and I'll send you a link. But we wrote it hopefully so that it was easy for people to understand who didn't know anything about this subject. So what I was wanting to do tonight was just, I guess, give a little bit of a summary of that paper and hopefully make it easier to understand where this has come from, what some of the issues are, and what we might do, what are some of the approaches that we might take to actually deal with this. So I'm sure that you've all seen, I mean, you're here, so you know that the issue exists, which is good. But I mean, the thing that really kicked us off was when we saw the cover on the Lancet journal. I don't know, did you all see that?
Yes.
Yeah, okay. So saying, I've got a quote here, and in fact, the conference I spoke at last week, the editor of the Lancet was there. We had a lovely chat. It was very good. But historically, the anatomy and physiology of bodies with vaginas have been neglected. And obviously, you know, so that was an example where the word women had been replaced with the phrase bodies with vaginas. And obviously it was there to avoid using the word woman, you know, because everybody knows what a woman is, really. They knew what they were talking about. And it was a really important issue that was being addressed there. You know, it was addressing the female data gap. And that's a really serious issue for women's health and also for the health of children. Because you can't separate the two. And so how we've had that, why that's a big issue is because we just haven't had the research. For a very long time, the male body has been considered to be the standard. Female bodies are so complicated. You know, we have these hormonal fluctuations, we do get pregnant, we do then breastfeed. All of those things, if you're doing research, they make it more complicated. So much easier just to start with a male body. And it doesn't just mean with human males. So medical research will start with cell lines, or will start with animals. And that research has been predominantly with male cell lines and male animals. So we've ended up in a situation where very often we don't have good treatments for the things that we need. And, you know, we saw it with COVID, where women who were pregnant and breastfeeding weren't able to be provided with a vaccine that had been tested on pregnant and breastfeeding women. And they knew that that was going to be a problem. They were told at the beginning of the pandemic, when vaccines were being developed, you need to make sure that we have research so that when we're putting out a vaccine, we actually have an evidence base to provide to women so that they can make their decision about whether they want to be vaccinated or not if they're pregnant or breastfeeding. So I thought I'd go through just to start, some of the alternatives for these words. So we've got, for women, we've got birth people, cervix havers, menstruators. Menstruators is very commonly being used. But also we have words like non-males or non-men, which, you know, given what I just said about research is, you know, really very, you know, that's how we've been dealt with. We're just not men. When it comes to pregnant women, words like birth givers or gestators or gestational carriers. And when it comes to breastfeeding mothers, and this one drives me crazy, and talk about families, which just makes women, the mother, completely invisible. So how have we ended up in this situation? Well, it's come from a concept called gender identity, which was developed, the concept itself and the term, like as we're using it now, was developed in the US in the 1960s. And then from that time, and especially through the 1990s, through a philosophical understanding called queer theory, it was refined. And so we get this situation where with queer theory it says that sex and gender are both socially constructed, but gender is the more important. And that goes back to with what Elaine was saying, that sex doesn't change. It's not socially constructed. How the meaning that we ascribe to sex can be socially constructed, but sex itself, whether you're male or female, is something that doesn't change. So we have this inherent conflict with that queer theory understanding, and that is why we are having this conflict with gender identity. And so that all happened quite some time ago, but particularly over the last decade or so, there's been an increasing number of people who have experienced a gender identity, which it's difficult to pin down a definition, but one that is very often said is that it's an inner sense of masculinity or femininity, or your understanding of yourself as a man, a woman, or not either of those, or both of those at the same time. So this idea that some people have got a gender identity and they experience that gender identity as being in conflict with their sex. And so that might mean that somebody who's female doesn't want to be referred to as a woman, that they prefer another term to be used for them. It's not because they don't necessarily understand their sex, although for some people they would say that their sex has actually changed. I think most people would say that their sex hasn't necessarily changed, but their gender identity is the thing that's really important to them. And that's why they want gendered terms to be used for them, rather than a term that references their sex. So we've ended up in this situation where people will say, not everybody who gives birth is a woman. You think, well, where did that come from? How did we get that term? Well, it came because they weren't using the word woman in a sexed meaning. If you go to a dictionary, like the Oxford English Dictionary, for example, it will provide you with 1,000 years of examples of how the word woman is used. And all of those usages are actually in its sexed meaning, as meaning an adult female person. And similarly with a word like mother. Mother, meaning a female parent, again referencing sex, is a term, well, linguists think it's probably pretty much the oldest word that exists. And again, it's always been used in its sexed meaning. And so this idea of it being reference to gender, so woman being somebody with a gender identity of woman, regardless of their sex, or mother being a person with a parent with a gender identity of woman, those concepts are so new. And they've come from one place, really. You know, these ideas have spread from the US, and the push to change language has come from the US. Frustrates me a little bit because sometimes people say, oh, there have been gender diverse people all over the world forever. And it's, if you're talking about gender being the expectations of the sexes and sex stereotypes, it's absolutely the case. There's lots of diversity around the world in terms of what's expected of people who are male and female, and also how people who don't meet the expectations for their sex are accommodated. That's absolutely been the case. But these ideas about gender identity, and particularly this change in language, has come from the US. It's spread to other Western countries, and it's now spreading to other places around the world as well. So for myself, in working out how to communicate and what we've described in our paper, we've really applied like a principle. We think that people should actually follow this. And that is that sex should be made visible when it's relevant. And it shouldn't be referred to when it's not relevant. So if sex is not relevant, then you don't need to refer to it. So we don't need to talk about a chairman, somebody here, because you don't have to be a man to chair a meeting. You know, we can use the word chairperson, or given we're talking about a specific chair, we can say chairwoman, but we don't really need to because the sex is not relevant at all. And it's the same with words like policeman. You know, you don't need to be male to work for the police, so we can talk about police officers instead. Sex isn't relevant. But when sex is relevant, when it's important or in fact critical to an issue, then we should be referencing sex in our language. So if we're talking about somebody who's getting pregnant, that person is female, and therefore referencing the sex by using the sexed term or using the term woman in its sexed meaning is going to be the appropriate term to use in the vast majority of circumstances, and certainly in any public health communication, in any policy, and in any research. So and the reason why we do that is firstly to avoid sex stereotyping, to suggest the idea that you need to be a particular sex to be a police officer or to chair a meeting. But it's also to ensure that sex-based needs and issues aren't overlooked. So if we avoid sexed language, when the sex of the person is important, then it's really easy to actually overlook issues of sexism. And if we're doing research and we're talking about the number of people in the research, and we don't say what their sex is, they might all be male, which would be quite typical, then we're missing really important information that would either tell us that this research may not be applicable to people who are female, or to tell us that actually if you're an ethics committee, you need to go back and change your study design because it would be unethical to carry out research just with male people when we have this big female data gap. So what happens when language is desexed around female reproduction, where sex is actually central? Well, we get dehumanisation of women, and the bodies with vaginas. I mean, when I gave my presentation in London last week, I had the cover on my front page, I had the cover of the Lancet on one side, and on the other side I had a photograph of a mum skin to skin with her new baby. That language, she was the body with vagina, except that's not right. That's not an appropriate way to speak about her. And for my work outside of this, because I never expected that I'd be in Edinburgh talking about language, but a lot of my work is around breastfeeding, and it's around the mother-infant relationship, and particularly in circumstances of adversity. So I work with women who interact with the child protection system. So somebody doesn't want me to talk. So women who, where there are concerns about her capacity to provide adequate care for her children, and the child, they may be considering taking the child into foster care or providing support to the woman or for the child to go into kinship care. So under those circumstances, what I've seen is very often language will be used to describe those women that will distance them from their child. And I did an interview with a woman for a study. It was right at the beginning of COVID, and her children were all in out-of-home care. And she told me about how a social worker in front of her daughter said to her, "You're just an incubator for your child." So when people started talking about, using the term gestators for women, I've heard this before. When we talk about surrogacy, people will go into all sorts of twists and turns to avoid referring to the woman who gestated and birthed the baby as a mother. Why are they doing that? They're doing that because of the meaning within the word mother. What a mother means to her infant, the importance of that relationship, and all of the connotations that go along with that. So these are, that's one of the issues. When we use terms that we have inappropriate inclusivity. So before, when I was talking about breastfeeding families, it's not, there's one person who's doing the breastfeeding, yeah? And very often, you've got really bad breastfeeding rates in Scotland. Very often it's the woman's partner or her mother who's undermining her in her ability to breastfeed her child. In order to support women's rights in relation to breastfeeding and the child's rights to breastfeeding, we need to actually identify who is the person who is doing this, who is the person who has the rights. It is the mother who has the rights. Other people have a duty to support her. They're not rights holders. So we also get inaccuracy. So we get some really classic things with statistics. So there was one that we cited in the paper from the NHS where they talked about 8 in 10 people would get pregnant after a year of intercourse without using contraception. Just was like, well, that would be a miracle. Just imagine. And in my own country during COVID, for our decision-making guide for pregnant and breastfeeding women, at one point somebody went through and just replaced all of the uses of the word women with people, which meant that they went from comparing severity of COVID between pregnant women and non-pregnant women to comparing the severity with pregnant people and non-pregnant people. And of course, non-pregnant people is not the same as non-pregnant women. And so they totally screwed up their statistics. So I'm sort of running out of a bit of time, but one of the things that I'm really concerned about here is the loss of data around sex. So we have organisations that are saying, we don't want you to collect data on sex anymore. We'd prefer that you just collect data on gender identity. And that's certainly happening in some places, so we're losing that data. But what also is happening is people just don't know what to do. So they're asking a question where they're saying, sometimes they'll say, what is your sex/gender? And they'll have examples like male, female, intersex, transgender. They're not collecting usable data on anything at all. And because of the female data gap, whenever we lose data on sex, that is likely to disproportionately impact women and children. There's also sex markers on health records are being altered, and this is transgender people who are getting their sex markers changed. This is not. This should not be happening. This breaches medical ethics, because your sex is important to the health care that you receive. And so people who do this are experiencing misdiagnosis, missed diagnosis, and delayed diagnosis. Because, for example, blood tests sent to pathology are not going to be giving, there's different ranges for different things for males and females. And so somebody who's female might have a result that would be perfectly okay for someone who is male, but they're not male, they're female, and the female range would show that in fact they have a problem, and it's not getting picked up. We reported on one of these cases in our paper, which was of somebody who was a transgender man who turned up at an emergency department with abdominal pain, told them, the sex marker said male, they told staff that they were a transgender man, and they didn't obviously initially work out what that exactly meant. In fact, they were pregnant and in labour. They had a prolapsed umbilical cord, and by the time that was identified, the baby had died. So that's just one example. There are others that are out there. I mean, Elaine was talking about the case of the university getting, providing information on catheterising a penis. And I think that, I don't know exactly why that happened, but you can see how it could happen because people get really confused around terminology. When somebody says they're a transgender man, for a lot of people they think, okay, so they're a man who's transgender, and not really having clarity around what that is. There's something called the Stroop Effect. I don't know if any of you have heard of the Stroop Effect. And there's a test that you can do, and what they do with that is that they flash up, and I may have the colours and words wrong, but things like there'll be a green background and it will have the word blue on it. And you are supposed to identify the colour, I think. But because there's this mismatch between the word and the colour, first of all, you're slower, so it creates a cognitive load that makes it difficult for you to think. And you also have more errors. And I think that potentially with the person who turned up at the hospital, pregnant but with the incorrect sex marker, that may have played a role, but also with the university as well, that it was just an error on people trying really hard to do the right thing and getting themselves tied in knots around it. So, it just beggars belief that people are doing that. So generally, I think in most circumstances, and particularly in public health communication, like Elaine was saying, the principle of public health communication, like the first principle, is to use plain language, the simplest language possible. And those who are most vulnerable, those who have the lowest levels of education, those who are being communicated to in a language that's not their first language, they're the people who are going to have the most difficulty, and they're the ones who are likely to actually have the poorest health outcomes, generally speaking. So when we change language to make it more complicated, to use words like cervix hazards or vagina owners or what are some of the other ones? There's so many. Menstruators. They're the ones who are not going to hear what's being said or not understand what's being said, and already they're at a disadvantage. But what do we do for people who don't identify as women or as mothers? When it comes to individual healthcare, it's an absolute no-brainer. We know this stuff. We use the language that people want us to use for them. That's what works for them. Doesn't mean that we change their sex marker, or that we don't treat them, provide them with appropriate care based on their sex, but we can, on an individual level, just use whatever language it is they want to use. We can also do things like use inclusivity statements. So we've got some examples of this in our paper, but there are so many ways to just say, for example, I think this one is actually from Scotland, saying the women's health policy, saying this guideline uses the terms woman or mother throughout. These should be taken to include people who don't identify as women but are pregnant or have given birth. Similarly, where the terms parents is used, this should be taken to include anyone who has main responsibility for caring for a baby. So they're being inclusive of people who are in unusual circumstances. Most people who've got full-time care of a child are going to be the parents of the child, but not all of them. So just need to make it clear who we're talking about. And it's the same with this. When we use sex language, to make sure that we ensure that we're saying, we actually are including people in this who might not have a gender identity that they would ascribe to this term, but we're referring to their sex. And so we're going to use that term, but we are actually including them in here as well. I've also used definitions sometimes in papers and saying things like, in this paper, mother refers to the female biological parent of a child, and woman to a person of the female sex. But different approaches are going to be appropriate in different circumstances. If you're working for a service that's providing care specifically to transgender people, you are potentially going to have a different approach than what you might use in a general health service. But whatever you do, making sure that things are as clear as possible and avoiding confusion is really important. And particularly when it comes to policy, making sure that you're including the people who should be included and excluding the people who should be excluded is really, really important. So at the end of our paper, we had a whole set of questions for people to think about, and I'm just going to read them out because we thought a lot about them. I can't say them off the top of my head. But these are principles for working out, what to do here. And so firstly we said, when sex is met, refer to sex. When gendered expectations of the sexes is met, use gender and clearly define it. And when gender identity is met, ensure it's distinguished from both gendered expectations of the sex and from sex itself. And think about, how can I be clear? How can I include the people who should be included and exclude the ones who should be excluded? How can I ensure that people understand what is being meant and can see themselves? How can I avoid dehumanising language? Am I engaging in cultural imperialism or improper use of privilege by requiring others to use language in a particular way? And when should compromises be made regarding clarity or precision or any other detriments to desexing language? And how can I mitigate against these detriments? And I think the thing is, if you know why you're doing something, and I know, and I know it's difficult, but if you know why you're using language in a particular way, and if you know, who will be impacted if you change it, and what might the repercussions be of changing it, then I think you're in a much better position to actually go, right, this is how we need to do it here. This is how we're going to account for the things that we need to account. And I think if people actually understand what the issues are, you're in a much better position if trouble comes.